Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. It's my pleasure to be with you today to discuss one of the most important topics which has been highlighted recently in the practice of medicine, which is pre-diabetes. First, I'd like to thank Merck Surono for organizing this event and Aspire Company for hosting us through the Zoom application. Before we go to pre-diabetes, we should not forget the fact that this is the outline of my presentation today about the epidemiology of pre-diabetes. What are the criteria to diagnose pre-diabetes? What are the international guidelines for dealing with patients with pre-diabetes? And then our Gulf country roadmap, which has been sponsored by Merck Surono, and the use of pharmacotherapy for the treatment of pre-diabetes with special focus on Metformin and conclusion. First, I'd like to draw your attention that diabetes is one of the most challenging health burden in the 21st century. You know that diabetes is really a major healthcare problem. And if you look for these statistics, which has been published by the International Diabetes Federation last year, it is that we have almost more than 463 million diabetic patients between the age between 20 and 79. This means that in this age group between 20 and 79, 1 in each 11 adult individuals is diabetic. And 50% of diabetic patients are undiagnosed, 1 in 2. And over 3 in 4 diabetic patients live in low to medium income socioeconomic standards. But I'd like to draw your attention to that 1 in 13 adults have impaired glucose tolerance. This is almost 374 million pre-diabetic patients worldwide. And the global health expenditure, 10% is spent on diabetes, which is almost 760 billion United States dollars. So we know this comes from the fact that diabetes is associated with many serious complications, whether macro or microvascular complications. It increases the risk of developing stroke. It increases the risk of developing myocardial infarction, heart failure, arrhythmias. It is the leading cause of blindness and retinopathy. It is the leading cause of non-traumatic amputations due to diabetic neuropathy, and it is the leading cause of end-stage renal disease and dialysis. Therefore, it is associated with many complications. And these complications are related to the degree of poor diabetic control. That is, if we compare it to those who have hemoglobin A1C below 6%, we will find that a steep rise of hemoglobin A1C is associated with increased risk of complications. And it is an exponential multiplication rather than an addition of the risk. And of course, the presence of complications will be reflected on the cost of expenditure. And as I mentioned, in the last year, it is stated that almost 10% of the global expenditure is spent of healthcare expenditures is spent on diabetes, and the presence of micro and macrovascular complications again will increase the burden economically. If we'll go for the United Kingdom prospective diabetes study, and we are all familiar with this slide, which showed that there is a progressive decline of the beta cell function over time. And that at the time of diagnosis of diabetes, we have almost 50% loss of the beta cells. What I'd like to withdraw your attention is that before this frank onset of diabetes, in this era of impaired glucose tolerance and postprandial hyperglycemia, which is present for years before the diagnosis of diabetes, and therefore in this era, patients seems not to be normal. And if we'll go for this again, very famous curve, which shows the relation between the insulin resistance and then hepatic glucose output production, and then decline of beta cell function and the secondary decrease of insulin secretion. Again, before the overt diagnosis of diabetes, as you see here, there is an era where there is development of macro and microvascular complications by preceding diabetes by 4 to 7 years. This means what? This means that even in the era before diabetes diagnosis, which is by nomenclature the pre-diabetic era for your patient, by 4 to 7 years, the patient is prone to develop micro and macrovascular diabetic complications. And that's why this area draw the attention of physicians in order to deal with this area before diabetes. That's why we found that the guidelines stated before, it was stated that to diagnose a diabetic patient, you should have a fasting blood glucose above 140. But after the realization that this complication could occur before the onset of diabetes, they went down and they made the diagnostic threshold for fasting blood sugar for diabetes is 126 instead of 140. But again, despite this, they found an error between the normal, which is 100 or 110 in some guidelines, and 126, which is associated again with this increased likelihood of complications. And this has been done from these studies. As you see in this study, which showed that there is an associated increased risk of composite cardiovascular event, whether the cardiovascular event, the coronary heart, the coronary heart disease, the stroke, or all-cause mortality, whether you are using the impaired fasting glucose according to the ADA or the impaired fasting glucose according to the WHO in violet, or in general the impaired glucose tolerance curve, or if you are taking the cutoff level of hemoglobin A1C according to the American Diabetes Association or the NICE. As you see, whatever you take as your benchmarking for the diagnosis of the diabetes, you will find that there is a statistical significant increased risk of composite cardiovascular event, coronary heart disease, stroke, and all-cause mortality. Therefore, this era of pre-diabetes should we should pay special attention for the patients in the pre-diabetic era. And again, when you will go for the blood glucose tolerance test, again, it is a pre-diagnosis of type 2 diabetes when the blood glucose levels are higher than normal but lower than the diabetic threshold. This is if you will go for the hemoglobin A1C. Now we are taking hemoglobin A1C as a normal between 4.8 and 5.6. It is not 6.5. 6.5 or more, it is diabetic. So between 5.6 and 6.5, this is considered as a pre-diabetic phase. It is not considered as normal hemoglobin A1C. And again, the fasting blood glucose between 100 to 125, below 100 it's normal, above 125, which 126 or more, it is diabetes. So again, in this era, it is considered as pre-diabetes. And if you will go for the postprandial or glucose or oral glucose tolerance test, 2 hours after a meal of 75 gram glucose, if you find it is above 140 but less than 200, again, this lies in the era of pre-diabetes. Again, different, as I mentioned, different institutions are stated different values for the hemoglobin A1C and the fasting blood glucose. As you will see, for the impaired fasting glucose for the ADA is between 5.6 and 6.9, which is 100 to 125. For the WHO, it is 110 to 125. And this slight difference does not make any importance because it depends upon you what guidelines you are going to stick to. If you are going to stick to the guidelines of ADA, which are more strict, you will take 100 or more as a pre-diabetes. But if you are more flexible with the IDF and WHO, you will take 110 milligram fasting and less than 126 as a pre-diabetes. And again, these are the criteria for diagnosing pre-diabetes as stated by the American Diabetes Association in its Standards of Care 2020. Again, it is stated that fasting between 100 and 125, or 2 hours between 140 and 199, or a hemoglobin A1C between 5.7 to 6.4%. Again, 5.7 to 6.4% is not considered as a normal hemoglobin A1C in non-diabetic individuals. It is considered as this patient is suffering pre-diabetes. So what to do for the individuals to check the criteria for testing the pre-diabetes in asymptomatic adults. Again, the American Diabetes Association guidelines in 2020 stated that we should consider testing in overweight or obese individuals. And this is the definition by body mass index 25 kilogram per square meter or more, or in the Asian American population who have thinner body mass index, it is the cutoff value is 23. If they have one or more of the following risk factors: if they have a first degree relative with diabetes, if they have high risk race or ethnic development of diabetes, if the patients have a high history of cardiovascular disease, if they are hypertensive or controlled hypertension on treatment, if they have low HDL or high triglycerides above 250, female ladies with polycystic ovary syndrome, which is a sign of insulin resistance, those who live a sedentary lifestyle, and other clinical conditions associated with insulin resistance like severe obesity or acanthosis nigricans. If the patient did a blood sugar test or hemoglobin A1C and found to be pre-diabetic, this patient should be tested at least every year. And women who have diagnosed with gestational diabetes mellitus, again, they should be tested every 3 years for the development of diabetes later on in life. And those individuals above the age of 45, and again, if the individual's initial test is normal, it should be repeated at least every 3 years, with considering more frequent testing if the risk status changes or the patient from the start has a high risk category. So what about the risk-based screening for type 2 diabetes in asymptomatic children or adolescents? Again, this is dependent upon the weight percentile for the children. Again, if the child has a maternal history, his mother developed gestational diabetes during his she's diabetic during his gestation. Again, if he has a first or secondary relatives of type 2 diabetes, again, the race is very important. Or if the child is developing signs of insulin resistance, like acanthosis nigricans or hypertension in young age, a young girl with a polycystic ovary syndrome, or there is a history of small for gestational age birth weight. This encourages the scientists to conduct trials in order to focus on preventing diabetes rather than control of diabetes. And this was the diabetes prevention program, which is extended to the diabetes prevention program outcome study. And as you see, this is the largest and the longest clinical trial, starting in 1996 and ended in 2014, which is almost 18 years study duration. And in this study, it was a multi-center trial of randomized control trial, which enrolled 3,234 patients or adults. And they were classified into 3 groups. Those who are on placebo, that means they are left alone without any intervention. Those who received the lifestyle change program, and those who received the metformin 800 milligram twice daily. And they would be followed for 5 years, and then there was a gap year for 1 year, during which they do what we call it modified lifestyle change program. And after this 1 year, they were continued for 12 years. Those who were receiving the lifestyle intervention kept on the lifestyle intervention alone. Those who were receiving metformin, they adopted the modified lifestyle plus metformin 250 milligram twice daily. And those who were left untreated as a placebo, they will be enrolled in the modified lifestyle change program. And the results were marvelous. It showed that a 30-minute of daily moderate physical activities, that is walking, for example, 5 to 7 days a week, plus maintenance of 5 to 10% loss of the initial body weight, resulted in 58% reduction in the subsequent development of diabetes. Therefore, the results from this diabetes prevention program were very marvelous. It showed that if your patient will increase his physical activity a little bit, which is, we call it moderate physical activity, and they succeeded in reducing his body weight by 5 to 10%, and as I mentioned, it's 7% is taken as the standard, you get 58% reduction in diabetes development. This means that 3 out of 5 adults treated by this lifestyle and weight reduction are going to be devoid or delayed the onset of diabetes. And if we'll go at the sizes of the different groups according to the body mass index, we will find that in those with body mass index between 22 to 30, we get 65% reduction of the development of diabetes with the lifestyle. For those with body mass index between 30 and 35, it is 61%. And as the weight increases, that is the initial body weight, body mass index is more than 35, you get lesser effect of the lifestyle. Why? Because we know that these obese individuals are associated not with only lack of physical activity, but also there is another underlying factor, which is a sign of insulin resistance. And that's why in this group of patients, it didn't find what is expected with those with lower body weight. Therefore, the lifestyle intervention wanes as weight increases. But if we will go for the sub-analysis with those receiving metformin, we'll find that metformin, as I just mentioned, showed significant reduction and the delay of the development of diabetes in these pre-diabetics, especially for those who have compared to 31% compared to 58%, as I mentioned, for the initial lifestyle. Therefore, it was compared to nothing done, which is a placebo. It had 31% reduction of the development of diabetes after 3 years follow-up. And this has been shown markedly in obese pre-diabetic individuals. Again, as I mentioned, the effect of lifestyle alone in obese individuals with a body mass index 35 or more was waned because of the associated insulin resistance, which has been overcome by the co-administration of metformin 850 milligram twice a day. And as you see, it was 53% less relative risk reduction of the development of diabetes in these obese pre-diabetic individuals. And again, if you will go for younger individuals, you'll find again with younger individuals, the effect is much more, 44% relative risk reduction compared for those above the age of 60. And therefore, it seems to be more effective in high-risk groups who are the young obese individuals with pre-diabetes. And again, those with higher fasting plasma level, that is between 110 to 125, therefore again, it showed 48% relative risk reduction of development of diabetes in those patients. Therefore, when you have all the signs of insulin resistance, which young age, overweight or obesity, and higher fasting plasma glucose, you will find the effect of adding metformin to the lifestyle most marked in preventing the subsequent development of diabetes. And this has been maintained for over the trial duration, over 15 years of treatment. There was a very long-term effect of lifestyle and intervention metformin to reduce the incidence of diabetes in this high-risk population. As you see, the relative risk reduction is reduced by 18%, which is 4.9 cases per 100 person years. And as you see, this was statistically highly significant with a p-value of less than 0.001. Again, the effect on weight loss, as you see, as expected, we all know that with the lifestyle, we will find a deep response at the start regarding the weight loss, and then this will fail by time, and then we'll reach a plateau. But if you will go for the metformin 850 milligram twice daily, you will find it starts from the initiation of treatment and is maintained with the same level up to 10 years. And as you see in this outcome study, the diabetes prevention program outcome study, the number was almost 2,766 patients. And therefore, you get an effect regarding the weight loss, and this effect has been maintained over 10 years duration. In this meta-analysis, which include 31 controlled randomized trials, including more than 4,500 non-diabetic patients who are at risk of developing type 2, that is pre-diabetic, as you will see in these studies, again, the metformin decreased significantly the new onset of diabetes by 40% versus placebo or no treatment. Therefore, even other randomized controlled trials, which are not on individual basis compared to the diabetes prevention program, showed the same results as the diabetes prevention program, that metformin is associated with significant reduction of development of diabetes in pre-diabetic individuals. But other drugs have been also shown to delay or prevent type 2 diabetics, like acarbose, bioglitazone, rosiglitazone, or other weight loss interventions like the bariatric surgery, the orlistat, or phentermine, as you see, are all associated with delaying the development of type 2 diabetes. Therefore, weight reduction seems to be an important and integral part for preventing diabetes. That's why the American Diabetes Association stated in a special section how to prevent or delay type 2 diabetes. What they stated, they refer patients with pre-diabetes to an intensive behavioral lifestyle intervention program. And the basis of this program is to achieve and maintain 7% loss of the initial body weight and increase moderate intensity physical activity, again, brisk walking, 30 minutes daily, 5 days a week. Again, the eating pattern is better to be changed to include the high fiber diet, the low carb, and low fat. Again, the American Association for Clinical Endocrinologists stated this pre-diabetes algorithm for the management. Again, like the diabetes lifestyle and for including medically assisted weight loss is very important in as a baseline for all individuals who are pre-diabetic. And then, according to the risk factors, if the patient have atherosclerotic cardiovascular disease risk factors, will be treated according to the algorithm. Whether the patient have hypertension, he will follow the hypertension route. If the patient has dyslipidemia, he will follow the dyslipidemia route. Again, if the patient is just having impaired fasting glucose or impaired blood glucose between fasting above 100 and less than 125, or the 2-hour postprandial above 140 and less than 199, again, you will assess the pre-diabetic criteria. If the patient has one criteria or low, you will use low-risk medications, which means medication associated with efficacy, safety, and cheap, and they can be given easily orally, like metformin. But if the patient have multiple risk factors, you consider with caution to add other medications like the TZDs or the injectable GLP-1 receptor agonist. Again, a combination between two drugs can happen, particularly if the blood sugar level is not controlled despite the medication. And by control means that you get the blood glucose curve from the pre-diabetic level to the normal level. You don't just give metformin in order to reduce weight, but also to correct the blood glucose level to go down for the fasting less than 100, for the hemoglobin A1C less than 5.7%, and for the postprandial to be less than 140. You don't just give the medicine and you don't up titrate the dose. No, you should up titrate the dose. And if one medicine is not enough, think of adding another medication. Again, the IDF recommend that when the lifestyle intervention alone hasn't achieved the desired weight loss and or improved the glucose tolerance, to start metformin in the dose by slowly up titrating the dose from 250 up to 850 milligram twice daily, depending on the patient tolerance and the avoidance of the side effects. And again, particularly in those ages less than 60 years and the body mass index above 30, as shown from the diabetes prevention program and outcome study, that those patients are less than the age of 60 and with body mass index 30 or more, these are the patients who get greater benefit with metformin 850 milligram twice daily. And before of this dilemma, in the Gulf region, our colleagues, they sat together and they think how to prevent diabetes in our area. And from this, they made the roadmap for the diagnosis of the management of pre-diabetes, a consensus of the Gulf country, GCC countries. And this is a guidance for us as a healthcare professionals to address how to diagnose and how to treat pre-diabetes in our area. Why they did like this? Because of the prevalence. As you see in this slide, according to the International Diabetes Federation, Saudi Arabia has the highest diabetes prevalence in the Middle East and North Africa region. 1 in 6 adults. As I mentioned early, in the internationally, it is 1 in 11 adults. But in our area, it is 1 in 6 adults. This means it is almost double the prevalence in other countries, which accounts for almost 4 million diabetics are present in our area, and at least, as I mentioned, 50%, which is almost 2 million diabetics, are among us, and they are not diagnosed. Again, it is estimated that 532 million people have impaired glucose tolerance in the coming 20 years. And as I mentioned, the pre-diabetes is a sign for increased risk of developing type 2 diabetes, heart disease, stroke, and overcause mortality. And people who are pre-diabetic, usually they don't know they are diabetic. And again, we don't have a standard approach for diagnosis and the management of diabetes in our area. Therefore, because if the studies showed that it is possible to delay, to prevent or delay the progression of pre-diabetes, type 2 diabetes, we should encourage ourselves in order to implement good practice for the detection and the management of pre-diabetes in our community. Again, if we'll go for this epidemiology, we'll find that the estimated prevalence of pre-diabetes is estimated to increase in Saudi Arabia from 15% in 2017 to 18% in 2045. And this will account for almost an increase of extra 3 million individual. And if you will go for the United Arab Emirates, you will find it is increasing from 14% again to 18%. And these are increasing the number, which again is reflected upon the development of diabetes, which will be reflected on the individual health as well as on the healthcare expenditures. We have many risk factors for pre-diabetes. Again, the age, 35 years or more, the socioeconomic deprivation, the polycystic ovary syndrome, ethnic groups, history of gestational diabetes, dyslipidemia, obesity, family history of diabetes, smoking, and presence of cardiovascular disease like hypertension, myocardial infarction, or stroke. And therefore, in our area, our colleagues started to put this risk assessment, how to assess the pre-diabetic risk in our areas, and they stated different international guidelines, Diabetes UK, American Diabetes Association, and Diabetes Canada, which stated whom you are going to test for pre-diabetes. And as you see, it included the age, the sex, the ethnic group, the relatives with diabetes, the obesity as measured by waist circumference, body mass index, blood pressure, physical inactivity, pattern of eating, whether it is vegetables or fruit eater or not, history of hyperglycemia, the level of education, the general well-being of the patient, as well as smoking. And despite genetic factors play a role, yet the modifiable risk factors such as obesity, sedentary lifestyle, and dietary habits, as well as lack of exercise, are the key determinants for the rapid development of type 2 diabetic in these pre-diabetic patients in our Arab world. Again, I just saw this slide which showed that pre-diabetes is associated with increased risk of the composite cardiovascular event, coronary heart disease, stroke, and all-cause mortality. Therefore, the key recommendations they adopted from the American Diabetes Association, the United Arab Emirates National Diabetes Committee, and the National Saudi Diabetic Guidelines, that they recommended what? Lifestyle management, regular physical activity, again 30 minutes daily, 5 days a week. Individuals should receive dietary advice and support. Intensive behavioral lifestyle intervention program to maintain 7% or more loss of the initial body weight. Aggressive management of associated cardiovascular risk factors, cessation of smoking, control blood pressure, control of lipid profile. And then you think of a pharmacologic management by using metformin or carbose, and the metformin therapy should be especially considered again in those below the age of 60 with a body mass index above 35 kilogram or more, or females with history of gestational diabetes mellitus. And despite these recommendations, it had many gaps. The first one, the link between current clinical practice and optimal management guidelines is not found. We don't have robust clinical guidelines for pre-diabetes. We have lack of awareness of pre-diabetes among physicians and patients and social media. Again, the need for pre-screening of risk individuals, especially those who are under insurance companies, because you know that insurance companies does not allow for checkup and annual evaluation of patients. It only allows for treatment of those who are diseased. But from the preventive point of view, they don't pay for that. Again, patient education to comply and maintain lifestyle and exercise is very important. And again, awareness, the social awareness of the community that pre-diabetes is really a major risk factor for diabetes and a major healthcare problem. Therefore, this diabetes prevention lies on three main pillars: healthy diet, loss of weight, and increasing physical activity. And this will result in prevention of the diabetic macrovascular complications. As you see in this Finnish diabetes prevention study and US diabetes prevention program, they found that again, there is a 58% risk reduction in development of type 2 diabetes, as I mentioned, by the lifestyle intervention. And if you will go for the US diabetes prevention program, again, this showed that the intensive change in the lifestyle along with metformin resulted in a reduction of development of diabetes over 4 years, and the study duration is almost 2.8 years. This is the initial phase of the diabetes prevention program. And therefore, any patient who has a fasting blood glucose of 100 milligram per deciliter or 2-hour plasma glucose of more than 140 milligram per deciliter should follow lifestyle modification and consider metformin as a low-risk medication for this patient in the patient treatment plan. And again, this is metformin has been shown in many studies as the DBP, the Diabetes Prevention Program Outcome Study, the National Diabetes Prevention Program, and the winning study compared with participants who progressed to diabetes. Lack of progression with diabetes at 15 years was associated with a 28% lower risk of microvascular complications in different studies. Again, the lifestyle management and metformin can delay the onset of type 2 diabetes by a decade. As you see, this is metformin alone in Virate. The hazard ratio is 0.82. This means that 18% reduction with the development of delaying the type 2 diabetes by decade, which is 10 years. Why we are stressing metformin? Because metformin is associated with minor gastrointestinal side effects, which tend again to wane over time. And as you see, these are the percent of self-reporting GIT problems in the past year, or those who are attributed to a metformin medication over the past 3 months. As you see, it is almost comparable to placebo and metformin. There was no statistical significant difference between both groups, despite we know that the commonest side effect with metformin was GIT upset. Both types of GIT symptoms reported decline throughout the program, and the rest of gastrointestinal symptoms were similar between both groups. by year 6 through year 9. And as you see, p value was not statistically significant. Therefore, if you start by metformin at a smaller dose and gradually up titrate the dose, you will avoid most of these gastrointestinal side effects. Therefore, metformin is safe and well tolerated over many years of use for diabetes prevention. The side adverse events potentially related to study medication were rare. Hypoglycemia adverse events were mainly non-serious for similar with metformin and the placebo. Other side effects like anemia were mainly non-serious, again comparable between metformin and the placebo, and there were no individual developed lactic acidosis or hypoglycemia during the 18,000 patient year follow-up in this diabetes prevention program. Again, in order to improve the gastrointestinal side effects of metformin, thanks for the companies and the pharmaceutical production, which resulted in what we call it the extended release form of metformin, which is associated with lesser side effects. Why? Because as you know, when you take it an oral tablet, the immediate release metformin will disintegrate and dissolute in the stomach, and this will be absorbed rapidly from the stomach, result in increased bioavailability, but it will irritate the stomach and the small intestine. But if you will give the extended release form through this pharmacology, when you will find that the tablet is formed of an inner polymer matrix and an outer polymer matrix, which does not contain metformin, and therefore the outer matrix will dissolve in the stomach, and then it will bypass the stomach in order to reach the intestine when the inner polymer matrix containing metformin molecules will be released, and this will minimize the gastrointestinal side effects. And as you see, this effect regarding the absorption, the light blue is the extended release form, whereas the dark blue is the immediate release or the standard metformin. You will find that there is rapid absorption with the immediate release and rapid drop of the metformin level within the circulation, whereas with extended release, you will find that the absorption is slower and longer and will maintain for a longer duration of time. And therefore, this will result in slower and steady state absorption to have a steady state level of metformin level within your body and avoidance of the gastrointestinal side effects. And again, this is the dosing schedule between the immediate release form, which can be given once, twice, or 3 times daily, and 3 times a day, whereas the extended release form can be given only once a day in order to improve again patient compliance. Therefore, we know that metformin shows a dose-response relationship curve. If you increase the dose with a smaller dose of 1,500, which is 850 or 750 extended release or 850 immediate release twice daily, you will find effectiveness with tolerance and safety. If you increase the dose, you will get better glycemic benefit, but the risk of GIT side effects will increase. Therefore, metformin is associated with many benefits through its anti-glycemic efficacy, reduction of weight, cardiovascular protection, cost effectiveness, effect on prediabetes and the subsequent development of diabetes mellitus. It acts as an insulin sensitizer, no hypoglycemia. Therefore, the summary, ladies and gentlemen, is that population in our area are at very high risk of prediabetes. Prediabetes should be considered as a priority for health promotion and patient education. And the education on clinical guidelines for prediabetes is now a key unmet need in our clinical practice. And there should be an effective screening and early treatment programs of prediabetes in order to improve the course of disease, delay the development of diabetes, or prevent it if we can succeed. Again, intensive lifestyle change and targeting cardiovascular risk factors represent the main stay of treatment decisions. And again, metformin can be added to treatment if lifestyle changes are insufficient. And thank you very much. By this I end. The floor is open for any questions. اللهم صل على سيدنا محمد. طيب، هل السؤال الاولاني، هل الليراجلوتايد علاج افضلي للسكري النوع الثاني عن الجلوكوفاج؟ We are talking about two different groups. According to the guidelines, metformin is the first line treatment or drug for type 2 diabetes. And you think of other medications if metformin and lifestyle fails to control diabetes. The use of liraglutide has been adopted by the European Society of Cardiology as well as the sodium glucose transporter inhibitors as a first line treatment for those with established cardiovascular disease who are drug naive. But for all diabetic patients who are recently developed diabetes and they are drug naive, you start by lifestyle and metformin. The signs of insulin resistance are obesity, acanthosis nigricans, hypertension, dyslipidemia, increased triglycerides, low HDL. It is which we call it the metabolic syndrome, hyperuricemia, and also it can be associated with smoking. For how long metformin used in pre-diabetes? It is lifelong. So long it is effective and no side effects, it is lifelong. And as I mentioned in the diabetes prevention program, it has been used for almost 18 years. If patient who recently diagnosed as a case of myocardial infarction or stroke, if his lab show only one criteria for pre-diabetes, what is the best therapeutic approach in like this situation? Start metformin or give him a chance for life? No. According to the guidelines, if the patient has established macrovascular complications, according to the European Society of Cardiology guidelines, you will start by drugs with cardiovascular benefit, which will be GLP-1 receptor agonist, or if heart failure, sodium glucose transporter inhibitors. But don't waste more time. Patient should receive medication. Don't depend on lifestyle alone. How many times we need to repeat hemoglobin A1C before label our patient as pre-diabetes? For all diagnostic criteria, diabetes or pre-diabetes, we don't count on one test. We should do it twice, separated by at least 2 weeks. Some patient on metformin experience passage of tablet on how can manage? Oh yes, this is a problem associated with the generics. That some generics, and you are all aware that one of the generics has been withdrawn of the market because of impurity and association with malignancies. Again, you will find this with some generic preparations, and what I advise for that is to change to the brand. Can you give metformin for diabetes for lead patient? Yes, but you are not expecting much effect because, as I mentioned, most of the effect of pre-diabetes in lean individuals is associated with weight reduction. Again, Dr. Sayed, the same question. I want to ask you, any pre-diabetes patient who is not obese, is it effective to start a carbose? Again, studies show that the best effect is with obesity, but again, for these individuals, and if you can encourage lifestyle and exercise and the control of other risk factors like diabetes, like hypertension and dyslipidemia, will be beneficial. Yes, metformin is approved by the FDA for the pre-diabetes, and it is approved by the American FDA and Saudi FDA, and it has been inserted in the pamphlet of metformin in our area in Saudi Arabia for almost 2 years right now. I think these were all the questions. I'd like to thank you all for attending tonight, and I hope I shared with you one important aspect in our clinical practice, which is dealing with pre-diabetes, which is our aim is to prevent diabetes rather than to wait and see patients with diabetes who are suffering complication. And by this I end. Thank you very much. Good night.